section due to prolonged labor in maternal temp. Sarah Carter is a G1, P1 now, operative vaginal delivery 4 hours ago, 3rd-degree laceration due to forceps delivery. And then we have Anna. Anna is a G4, P3. She had a postpartum, or she had a C-section four days ago, and she's in the hospital still because she developed a DVT and she's on a heparin drip. Which client do you think you should probably check on first? All of these are your clients. You're going to see all of them at some point. Where do you head first? What do you guys think? We can't go everywhere simultaneously. Most at risk. She is the closest to delivery. One of the leading causes of maternal mortality is postpartum hemorrhage. And Lauren has the greatest risk for postpartum hemorrhage. She delivered 2 hours ago. We need to make sure she's hemodynamically stable. She's at greatest risk. Now, that doesn't mean that we have to go in there and stay in there for the next 4 hours. We just need to go in there and do what? Make sure what? She's not bleeding, right? And then we can go check on the other two. So Lauren's our 26-year-old, G6, P4. She delivered her 4th baby at 39 weeks via C-section due to macrosomia. She was in labor for several hours and wasn't progressing. She developed a temp. A stat C-section was performed when the baby showed signs of distress on the monitor. Baby was transferred to NICU. No one has returned yet to give Lauren an update. She was just transferred to your postpartum unit and you are her nurse. What risk factors in Lauren's history are you concerned about for postpartum problems?
Abortion.
Okay, so she's had multiple babies? Okay. Okay, macrosomia. So the multiple deliveries, the macrosomia, what else? Anything else concern you? Okay, she had a C-section. She was running a temp. Okay, she's young. Huh? Okay, maybe her abortions, potentially. Anything else? There's still more? Yeah, there's a couple more. Where is her baby? Attachment. Right? She's a setup for a few different problems. So we already talked about she's a grand multipara. She's had her 4th baby. She had a C-section. She had a macrosomic baby. She was in labor for several hours. She developed a temp. She had a stat C-section. Baby was transferred to the NICU. So there's lots of reasons why we would just want to go poke our head in and make sure that she was all right. So we do an assessment. This is our assessment. Breast soft, non-tender. Uterus unable to assess due to pain. Bladder, Foley's draining. Bowel sounds, they sound diminished. Lochia, small to moderate on the peri-pad. Her abdominal incision is clean, dry, and intact. Her epidural site shows no signs of infection or bleeding. She doesn't have any hemorrhoids. Edema +2 in both lower extremities. She has on her STDs. Emotional status quiet and withdrawn. Pain 4 out of 10. What are your concerns? Okay, emotional status, what else? Her edema, okay. Anything else? Who said uterus? She won't let you assess it because it hurts from her C-section. Is that okay? Can we just forego it? So we're worried about bleeding, we're worried about pain, we're worried about infection, we're worried about bonding, we're worried about DVTs. Based on all the things that you said, right? What is the priority? Bleeding. That was a no-brainer. Nursing is all about prioritizing. We're not octopi. We can't do 11 million things all at once. We can't see all of our patients simultaneously. We have to decide who is most in need and what is their biggest need and start there. Okay, one of the main causes of maternal death is hemorrhage. We just talked about that. The number one cause of early postpartum hemorrhage is uterine atony, the number one cause. Lauren just delivered, and so she's at greatest risk for bleeding due to uterine atony. Does she have any other risk factors for bleeding specifically? What do you guys think? She can't breastfeed, the baby is gone. Anything else? A macrosomic baby? Any other risk factors specifically for bleeding? Prolonged labor, multiparity, right? So she's a setup. She's a setup for bleeding. Okay. So you want to assess Lauren's fundus, but she's reluctant to let you press on her abdomen because it's still sore from her C-section, understandably, right? Anyone in here been to the OB unit yet and had a patient that was post C-section? How happy are they to have us smash on their abdomen? Not at all, right? Can we just skip this? I get asked that every single day. I go to the unit with my students. Well, I want to assess your fundus, but she had a C-section, so I don't think I should. I'm like, why? We definitely should. Now, that doesn't mean that we just, go in there and just, being all rough, but can we skip this assessment? No. So what can we do? Yes, medicate prior to the assessment. Do we have that power? We do, we have the power. Do we have to wait until later to give her ibuprofen or whatever? Usually not. So we go ahead and medicate her. While we're waiting for that to kick in, is there any other assessments we can do to let us know about her current hemodynamic status? Yeah, blood pressure, vital signs, pulse. A decreasing blood pressure and an increasing pulse are signs that we're losing volume. And that's the same. I don't care if you're a postpartum woman or an 85-year-old man. You have blood pressures that are trending down and heart rate that's trending up. You're losing volume from somewhere. So Lauren's temp is slightly elevated, but the rest of her vital signs are normal. We still have to assess her fundus, because if it's not firm, we need to address that, but we can go ahead and look at her Lokia pad. What is the normal amount of lochia for a client who's less than 24 hours? Which of these pads? Scant, light, moderate, heavy?
Moderate.
Moderate is expected for someone who's less than 24 hours out. So that means that she's changing her peri pad usually about 6 times a day on average. Lochia rubra is going to be heavier than Lochia serosa and Lochia alba, right? It's going to be like a very, very heavy period. And this is normal. It shouldn't stay this way. We talked already that Lochia rubra should last how long? Yeah, anywhere between 1 and 3 days. And then it should start to taper off. But you assess Lauren's lochia and you find that her pad is now saturated. What should you do? We can ask her how long she had it on. Although when she arrived to your unit 2 hours ago, they said it was light, right? So ask her how long she's had it on, but now we definitely want to assess her fundus. We probably don't want to continue to wait, even though she's probably going to be uncomfortable. We can talk to her, we can coach her through it. We can get her to breathe while we're doing the assessment. We will be as quick as we absolutely can be, but we need to know whether or not her fundus is boggy or firm, because that's going to determine our next step. So Lauren's fundus is not firm. So what do? We massage it. So sometimes students are a little bit misled by the word massage. They think massage sounds like wonderful and soothing and relaxing. I'm getting a massage. Is that what we're talking about here? No. We're talking about like, we are pressing down hard. We are rubbing hard. We are trying to get that uterine muscle to contract. We're not just doing a little bit of light. No, we are like rubbing, mushing, smashing, like we're kneading dough. So it does firm up with the massage, but it relaxes again as soon as you stop. What may cause this? Anyone have any idea? Okay, potentially lack of oxytocin. So the number one cause for postpartum hemorrhage in the first 24 hours is uterine atony. What's the number one cause of uterine atony in the first 24 hours? A full bladder. Most common cause. Not the only cause, but the most common cause. And the other ones are everything that we've already said. Prolonged labor, macrosomic baby. Maybe in the event of a C-section, some retained placental fragments. When we have a C-section, how is the placenta delivered? Does it slide out of the vaginal canal like it does with the vaginal delivery? They manually remove it. They reach their hand in there and they scoop it out. Might some little fragments be left behind? Possibly. So anytime we have a manual removal of the placenta, we need to really assess that placenta. Anyone in here been in a delivery, either vaginal or C-section? So usually the nurse after the delivery, she's over there in that little placenta bucket doing this, right? What are they looking for? Make sure it's all there. Make sure the whole placenta is there, that we're not missing any pieces of it. Because that does happen sometimes. What are some pharmacologic interventions we can do when your fundus is not firm? Okay, Pitocin, anything else? Is Pitocin all we have at our disposal? So the question is, would an indwelling catheter count as pharmacologic? Not technically, although it wouldn't be a bad idea, since we know that a full bladder is the leading cause of boggy fundus. But we're talking about actual, like, medications. What else besides oxytocin? Because for someone who was having a prolonged labor, they probably were on oxytocin probably for several hours. It doesn't always work real well for clients that have been receiving it for several hours. Why is that? Their body gets used to it. We have to have something else in our arsenal. What do you guys think? Is it the miso one? It might be the miso one. It might be the Methergin one. Misoprostol
You're working
is
on your whole
Cytotec.
breathing? You're working
It
on your
also
whole
might be
breathing?
Hemabate. So there's several things in our arsenal that we can use. We have to pick the best one for our client. So the doctor orders Methergin, but that might not be the best for our client. What pre-existing condition would Lauren be contraindicated to receive Methergin if she had it? What pre-existing condition is a contraindication for Methergin? It is pre-E, or gestational hypertension, or chronic hypertension. Any hypertension. If your client has hypertension in her history, Methergin is not an option. If your client has any sort of pulmonary history, even something as simple as asthma, Hemabate is not the best option. So you have to know something about your client. What are some signs that would indicate that Methergin had worked? Lauren doesn't have hypertension, so we go ahead and give the Methergin. How would we know that it worked? A firm fundus. That's why we're giving it. It helps to contract the uterine muscle. It's very, very good at contracting smooth muscle. What is the uterus? Smooth muscle. So firm fundus and decreased lochia is what we're looking for. It works within minutes. It's given IM and it works within minutes. Okay, but she's lost a lot of blood. She lost a lot of blood in delivery, and now she's lost more, and the blood transfusion is ordered. Anyone think you're a witness of blood transfusion yet? No? Well, I guess that's great. You guys had some great, healthy women. Blood transfusions are by no means uncommon in this group. What are some nursing actions that you would need to consider when implementing related to hemorrhage? Just hemorrhage in general. Your client is hemorrhaging. What are some things that you need to probably be sure that you do or watch for? Okay, so we need to replace the volume somehow. Should they have a large bore IV? Yes. Anything else? Okay, watch their change in mental status perhaps. Skin color, anything else? Oxygenation. Yeah, blood pressure, vital signs. We might need to administer some oxygen. We'll definitely want to have a large bore IV. We're gonna need to be prepared to draw a CBC and a type and match, or type and cross. We need to be watching for pallor, headache, fatigue, and provide emotional support for anyone that we are considering might need assistance with hemodynamic stability. Some things to consider when actually administering blood. We would definitely want to give it if our hemoglobin is less than 10. Before administering, every client needs to be type and crossed. We want to assess the vital signs at baseline and then hourly. Stay with the client at their bedside, looking at them in the face, eye to eye for at least the first 30 minutes. Why is that? What are we watching for? A transfusion reaction. Very good. If we do have an acute hemolytic reaction, what might we see? Chills, fever, tachycardia, tachypnea, hypotension, anaphylactic reaction, wheezing, shock, urticaria. If a reaction occurs, no matter what type of reaction it is, what do? Stop the transfusion immediately. We'll figure out